Good morning, everyone. We're going to talk about Section 8 renal problems. The new PowerPoint deck does not have many slides for this chapter 9, so there's lots of information that we're going to try to pack in and pull out of the book, even though there may not be many slides. The first thing we're going to talk about is dysuria, and it's probably a very common occurrence that you're going to see in practice, and it's that subjective feeling of pain or burning when you try to urinate. You can have increased frequency, urgency, you may have hesitation. Another term associated with is strangury. I believe that's how it's pronounced, and that's a slow, painful urination. Dysuria can be associated with several different medical issues or medications, but most often it's related to a lower urinary tract infection. Also, certain SSRIs can cause dysuria, and those can include Celexa, Lexapro, Paxil, Zoloft. Painful urination is most often associated with a bladder problem and not related to kidney disease. Other conditions that it may be associated with could be bladder tumors, chronic renal failure, kidney stones, and it can also be associated with conditions outside of the renal system, such as prostate issues, vaginitis, sexually transmitted diseases. A urinalysis is the cheapest, least invasive, and most convenient test that we have that we can further explore if a patient has a infection or other renal issues. Next, let's talk about hematuria, and we know that that is blood in the urine, and it could be gross hematuria, which you're able to see when you're looking at a urinary specimen, or it could be occult, which is microscopic. And when looked at underneath the microscope, this would be characterized by more than 3 red blood cells per HPF, or high power microscopic field. You can have asymptomatic hematuria that could be caused by infections, vigorous exercise, viral infections, traumas. It's important to clarify whether your patient may be having a transient versus a persistent hematuria. And the transient would be just a single occasion, where persistent would be 2 or more consecutive occasions with blood in the urine. Testing of choice would be urinalysis. For hematuria, there's always the suspect of that the cause is of renal origin. You may also consider a urine culture and sensitivity. I want you to be sure and look in the book on page 624. You're looking for Advanced Assessments 43.1 of urinalysis, and it breaks down all the different components of what is found in urinalysis, and then the common differential diagnoses that may be associated if you have the certain categories that test positive. This is an area where it's important to consider your differential diagnoses. The causes are going to be grouped according to the anatomical site of the blood source. For example, isolated hematuria with no urinary components. It could be from bleeding anywhere in the renal pelvis to the urethra, but is rarely associated with systemic diseases. We'll talk about this again, but RB cast are usually indicative of a microscopic amount of bleeding coming from the kidney. It's usually seen as an injury to the nephron. As you continue with the differential diagnosis, bacteria is suggestive of an infectious origin. If there's gross hematuria, it could be an indication of acute cystitis or urethritis, which is more common in women. It's important to get a good drug history and a dietary history when evaluating hematuria. In the dietary component, caffeine, spices, tomatoes, chocolates, certain foods can cause hematuria, as they act as a bladder irritant. It's also important to assess which foods they have eaten. I have once had a patient who came in with a pinker 10-inch urine, and it was the time of the season when beets had come out, and she loved beets and had been eating quite a few, and we came to find out that that had tinted her urine. So be exploring lots of options if you cannot find a reason for the color change in the urine. Also know that alcohol and cigarettes can be bladder irritants. In your book on page 625, be sure and review the medications that can cause inflammation in the nephrons, antibiotics, NSAIDs, allopurinol, Dilantin, etc. As we mentioned earlier, the most common tool used to help assess for blood in the urine is a urinalysis. And one of the drawbacks of a urine test is that it detects the presence of heme, which is the iron containing protein of hemoglobin, but it does not actually pick up on RBCs. Be sure and look on page 626 for the differential diagnoses associated with hematuria. It gives an origin of where you think that the blood may be coming from, and then the differential diagnoses that could be associated with it. So that's table 43.1 on page 626. Let's talk next about proteinuria. It's proteins found in the urine, and these are primarily globulin and albumin. Proteinuria is when there is renal pathology associated with these, most often of glomerular origin. There can be excessive protein in the urine, as a result of emotional stress, excessive exercise, acute illness, which seems to indicate a benign process. But it can also be reflective of serious issues. Proteinuria may develop due to the overproduction of plasma proteins, such as Bench-Jones proteins associated with multiple myeloma. So it's important to assess for how much protein is in the urine, and the most accurate way to do that is with a 24-hour urine collection. A 24-hour urine collection with more than 150 milligrams of protein is considered abnormal. Proteinuria may occur from benign or functional causes, or it can be a result of an acute or transient condition. So when you're working up your differential diagnosis, it's important to take these into consideration. It can be caused by environmental factors that could include emotional stress, exposure to cold, high levels of norepinephrine levels. I apologize if there was a break. The video decided to render itself, but we were talking about differential diagnoses for proteinuria. Another cause could be orthostatic issues, exercise-induced proteinuria, and then I think we had mentioned environmental factors. On page 627, there's a table talking about proteinuria, the types of protein that may be found in your 24-hour urine, and then the associated diseases that can be seen with that. Other testing for proteinuria is going to include chemistries, which will include your fasting blood sugar, do a lipid profile, urine culture and sensitivity, and then a CBC. And management is going to depend on the underlying cause. Next, let's talk about some urinary tract disorders. And the first one is going to be urinary incontinence. And this is the involuntary loss of urine from the bladder, most frequently seen with women, but can be seen in older men. Just to give you a little number, urinary incontinence affects more than 25 million Americans. It has direct cost of greater than $26 billion per year. And one study estimated that over 40% of American women are affected. I believe that it is much more prevalent than what is discussed. So I believe that this is something important to talk with your patients about. There is a big association between urinary incontinence and major depression. The book breaks it down as transient versus persistent incontinence. And transient is characterized by sudden onset, could have different causes such as delirium, infection, medications, or systemic illnesses. And is it a new onset incontinence? In the book on page 630, there are there is a table that classifies the types of urinary incontinence. I encourage you to look at that. It's broken down into the type, the cause, how to assess, and the management. These patients may present without any complaints of urinary incontinence when you're doing just a regular H&P, but it's important to assess for what their history is, get a good medical and surgical history, including a patient's voiding history. You want to know how many times they may go to the bathroom day or night, the amount of urine, the fluid intake, including what types of fluids they've consumed, and then include what types of urinary incontinence they may be having. For example, if they sneeze, if they jump, do they have increased frequency or any pain? All of these factors are going to help you build your diagnosis. It's also important to include a neurological assessment, as CVAs and Parkinson's disease can have an impact. You're going to want to do a good abdominal exam, rule out any constipation, fecal impaction, masses, distended bladder, or any other causes that could lead to incontinence. A pelvic exam may reveal the degree of the pelvic floor strength, and a rectal exam should be done to determine the sphincter tone and if there's the presence or absence of stool that may suggest complications such as fecal impaction. During your physical exam, it's important to assess for CHF, as 50% of patients with CHF do experience incontinence. Testing to include to further evaluate this would be urinalysis and a culture and sensitivity. You may want to get a cath specimen to assess for post-void residual volume, or if you have the luxury of having a bladder scan, to be able to assess it that way. Urinalysis may result as normal, but may show elevated levels of sugar in patients with diabetes, protein in patients with glomerular disease, and white blood cells in patients with bacterial infection. As you work through your differential diagnosis, it's important to identify the type and the cause of the incontinence, which in turn will lead you towards management and treatment decisions. As incontinence is mostly seen in our older patients, it's important to assess for any delirium, dementia, or as we talked about, Parkinson's or stroke symptoms that could all lead to urge incontinence without the patient being aware. If there's local irritation in the bladder or outflow obstructions, this can lead to urge incontinence because the smooth muscles in the obstructed bladder can contract more frequently. It's also important to assess how well the bladder is able to store urine and properly empty urine. Failure to store may result in a hyperactive or a poorly compliant bladder. And then the assessing of the pelvic floor and the bladder outlet and the sphincters may show hypermobility in their urethra and diminished outflow tract resistance, which can lead to stress incontinence. And of course, there can be mixed types of incontinence. In the book, each of the types of incontinence is broken down, starting on page 632 to how is the best way to help manage it. I encourage you to look at those individually. On 633, there is also a table of drugs commonly prescribed for urinary incontinence. So both sections have some great information, and I encourage you to review those with more detail. It's important to have close follow-up with the patients that have urinary incontinence. The book suggests this be done bi-weekly at first, as the patient is being taught therapeutic exercises and any medication modification of dosing being conducted. The patient also needs to be monitored for any adverse effects of medications or any issues with orthostatic hypotension. Next, let's talk about lower tract. Let's make sure lower tract infections. I didn't need to move forward just a second here. So lower tract infections occur when a normally sterile environment is invaded by bacteria. And this can occur in the urethra and the bladder, and for men from the prostate. Infections can be acute, chronic, recurrent, complicated, or uncomplicated. And so, based on what type of infection is, will determine how you will plan to treat it. Lower UTIs are common for women and make up approximately 20% of women annually and 1% of men annually. These patients may present with a variety of symptoms. Women may present with urethritis and cystitis simultaneously. Some of the most common symptoms reported by both women and men is painful urination, urinary frequency or urgency, increased urination at nighttime, blood in the urine, low back or suprapubic pain, or a cloudy, foul smelling urine. In our elderly population, it's important to make sure of what their mental status is, because sometimes this is the only indication that there's a urinary tract infection if an older person has become confused. In the outpatient setting, you're going to want to get a clean catch urine. Diagnosis of a UTI is based on the results of the urine specimen and subjective findings of the patient, especially if there's more than 100,000 organisms per milliliter. UTIs can be treated with antibiotic therapy based on knowledge of the most common bacterial etiologies in your area. However, a urine culture and sensitivity will aid in identifying the specific organism and then directing that you have started them on the correct antibiotic. So in the book on page 639, there is a table that describes drugs commonly prescribed for UTIs, and we're not going to go into each of those in detail. I encourage you to review them, but something just to make of note: uncomplicated lower urinary tract infections can often be treated with just a 3-day course of medication such as Bactrim. The book makes note that for epidemiological surveillance that there's been increasing rates of resistance to E. coli, to ampicillin, and sulfonamides, where only a small percentage of these isolates were resistant to macrodantin, which is known to concentrate in the urine. So a 7-day course of nitrofurantoin or macrodantin should be used as an alternative in patients with demonstrated or documented sulfa allergies, or a patient with a previous antibiotic use in the past 3 months. So be sure and read through the different medications that are here, and so you'll know what your options are and what is the best choice for your patient. Most often, your patient does not need to follow up with you after a UTI unless their symptoms have not improved. But if their case is considered complicated, or it's a repeated UTI, or there's concerns for pyelonephritis, or the patient is pregnant, they should have a follow-up urinalysis or culture to assess that the bacteria has resolved and treatment has been effective. Let's move on to an upper urinary tract infection, which is pyelonephritis, and that's an infection of the kidney characterized by infection within the renal pelvis, the tubules, or the interstitial tissue. It can be unilateral or bilateral. It can happen in both men and women, and its incidence is higher in older adults. It is typically caused by fecal flora that colonizes and ascends along the urinary tract to the kidneys. 75 to 95% of these cases are E. coli. These patients may present with classic triad of fever, CVA pain, and nausea and vomiting. The patient may present with shaking and chills, unilateral flank or localized back pain over the affected kidney, or the patient may be largely asymptomatic and then progress into full-blown sepsis very quickly. And as we mentioned earlier, in elderly patients, they can have altered mental status, which may be one of the initial presenting signs. On physical exam, you can recreate marked tenderness of the deep abdominal palpation or percussion over the flanks and back that lay on top of the kidneys. This is important to include in your physical exam if you're checking for CVA tenderness. Diagnosis of pyelonephritis is confirmed by urinalysis, which will be positive for bacteria, proteinuria, leukocytes, urinary nitrates, hematuria, pyuria, and as we mentioned earlier, WBC cast, which are reflective of the passage of neutrophils through the renal tubes, as well as doing a urine culture. Other testing to perform to determine diagnosis may include cystoscopy, renal ultrasound, or an IVP. However, the nuclear medicine based DMSA scan is most sensitive for detecting pyelonephritis and any renal scarring. The book also mentions one of the key ways to differentiate between pyelonephritis and cystitis is the presence of WBC cast in the urine, and that is diagnostic for pyelonephritis. Treatment is to be aggressive to prevent permanent damage to the kidneys. The goal is to get antibiotics into the renal medulla, which seems to be more important than the serum or urine drug levels. Oral antibiotics can be used for mild to moderate cases of acute pyelonephritis and also dependent on other symptoms that the patient may have. Hospitalization may be needed if your patient is not able to maintain fluid intake and tolerate oral antibiotics, or if there's concerns for bacteremia. Treatment courses for antibiotics should last at least 7 days for mild to moderate cases and 14 days for severe cases. So be sure and review the commonly prescribed medications from table 44.2, which is on page 640. Follow-up for these patients should be within 48 hours if being treated in an outpatient setting to assess for responsiveness and improvement of symptoms. If you have a patient that has recurrent pyelonephritis, you may need to reculture at weeks 2, 6, and 12 to make sure that the infection has cleared completely and stays resolved. And if there is that chronic nephritis diagnosis, it's important to refer to nephrology to avoid damage to the kidney. Let's next talk about kidney stones, and these can be formed from calcium, struvite, uric acid, or cysteine. The most common ones are the calcium salts, approximately 75 to 85%, and the struvite falls in next at 10 to 15%. These stones are often the cause of acute episodes, including an obstruction, infection, and severe pain in adults. They can occur in individuals anywhere from 20 to 60-year-olds, but are most common in the 20 to 30-year-old range. Calcium stones are most common in men, whereas struvite stones are more common in women. There's a table on 646 that gives more information on the different types of stones, the causes, and how they'll be managed. On presentation, your patient may complain of symptoms dependent on where the stone is located, the size, and the type of the stone. Usually the pain is caused initially with a sudden renal colic, which you're not able to get the pain to abate based on any medications, positions, or other measures. The pain then can progress to more of a constant pain at the level that can be excruciating and intractable. Other symptoms may include nausea, urinary frequency, vomiting, diaphoresis, dysuria, hematuria, and weakness. The patient objectively may have abdominal distension, will have guarding on palpation, flank tenderness, and may have decreased or absent bowel sounds. Fever may be present. Diagnostic workup should include a urinalysis, a CBC, and chemistries. You may see that there's gross or microscopic hematuria in the majority of the cases, but may be absent in approximately 30% of the cases. Diagnostically, a KUB may be ordered, or an abdominal or transvaginal ultrasound for a pregnant woman or someone in childbearing age, or a non-contrast CT. So treatment goals are to decrease the symptoms and complications arising from the stone. It's important to have your patient have increased water intake. Most stones that are less than 5 millimeters will pass on their own. pain management is important, and studies have shown that NSAIDs can be equally as effective as narcotics, and that the NSAIDs also have the effect of relaxing the ureteral smooth muscles, which may help facilitate stone passage. Antispasmodics such as oxybutynin can provide temporary relief. Certain drugs help to reduce urinary excretion of stone forming substances such as your thiazides. Um, then, importantly, loop diuretics such as Lasix and triamterene increase um, calciuria and typically can worsen renal stones. So just be aware if you have someone that presents with renal stones, determining what their type of stone is and if they're on any of these medications. There are several surgical and non-surgical interventions for managing kidney stones, so I encourage you to look at those on page 648 on table 44.4. This last section we have is kidney and bladder disorders, and we're going to talk about acute kidney injury, AKI, also known as acute renal failure, and this can be a sudden or rapid deterioration of renal functioning. And it's defined as a 1.5-fold or greater increase above the reference value of the creatinine. It's assumed that the injury has occurred within the last week, or urinary output is less than 0.5 milliliters per kilogram per hour for more than 6 consecutive hours. And the reference serum creatinine should be the lowest creatinine value recorded within the last 3 months of the patient's event. AKI can also be caused by intrarenal injury associated with renal hypoperfusion or nephrotoxic drugs. AKA is divided into 3 major groups. We have prerenal azotemia, intrarenal azotemia, and postrenal azotemia. And just to talk briefly about them, the prerenal is any condition that leads to the overall decrease in renal perfusion. This could include hypovolemia, decreased cardiac output, renal vasoconstriction. It could be related to medications such as NSAIDs or ACE inhibitors. In the intrarenal azotemia, this are disorders that actually impact the renal parenchyma itself, such as glomerulonephritis or acute tubular necrosis, or nephrotoxic drugs, aminoglycosides. This can also be caused by interstitial nephritis, which could be an allergic reaction to many drugs or even transfusion reactions. And then we have the postrenal azotemia, which refers to any cause that might lead to an obstruction of the urine flow from the kidneys, including urethral obstruction, bladder neck obstruction, and urethral obstruction. Ureteral obstruction and urethral obstruction, Major causes could be from BPH or a bladder cancer or any metastatic diseases affecting the urinary tract. So be sure and review box 45.1. These include the major causes of acute kidney injury. Symptoms of acute kidney injury are usually not present until the glomerular filtration rate falls to approximately 10 to 15% of normal. Some of these symptoms that can be seen are the effects of accumulation of toxic metabolites such as urea, and you can have malaise, nausea and vomiting, itching, mental status changes, fatigue. Urinary output changes are dependent on the stage of the acute kidney injury and its precipitating causes. So it's important to get a detailed history that might help to give you clues to the causes. The patient should be asked about any illicit or new prescription drug use, herbal preparation, surgery, trauma, any new infections that might lead to possible causes of kidney damage. Diagnostically, BUN and creatinine levels are needed to diagnose an acute kidney injury. It's important also to monitor electrolytes that may reflect any abnormalities that develop secondary to the change in renal function. The main challenge in AKI is to determine the underlying cause, and one of the leading underlying causes is nephrotoxic agents that can damage the kidneys. And as we've talked about, those can be certain drugs, antineoplastics, anesthetics, antibiotics, and anti-inflammatories. As we all know, imaging contrast, even biological substances, um, environmental agents from pesticides and organic solvents, heavy metals, and then certain plant and animal substances such as mushrooms or snake venoms. Let's next talk about chronic kidney disease, which is the progressive loss of the functioning nephron, and this leads to end-stage renal disease. It's reported that chronic kidney disease affects approximately 13% of the U.S. population. Risk factors include the use of analgesics, cigarette smoking, cirrhosis, multiple myeloma. On page 660, table 45.1, there's a guide on ways to differentiate the stages of chronic kidney disease. This is important to know also if someone has this, at what level they are in regards to if you need to make adjustments for any medications that are dosed according to kidney function. Management includes determining and trying to control the underlying causes, monitoring for changes in renal function, and trying to conserve treatment of the physiological effects of chronic kidney disease, and instituting treatments such as dialysis or renal transplantation as needed. With these patients, it's important to manage their blood pressure, their fluids and electrolytes. It's important to treat for anemia, as this can increase with damage to kidneys. Patients with chronic kidney disease should be referred to the nephrologist due to the progressive disease. Let's talk next about renal tumors. They are abnormal tissue formations on or around the kidney that can contribute to renal disease. Risk factors include obesity, exposure to asbestos, cadmium, gasoline, and cigarette smoking. Symptoms vary depending on the size of the tumor, and oftentimes the growth of the tumor is silent. Patients are asymptomatic. Often the only outward symptom might be hematuria. Some patients may have a complaint of a dull, achy flank pain or abdominal mass. Other tests that can be used for determination of the diagnosis may be an IVP. However, these tests do not indicate whether the mass is solid or cystic. And so generally speaking, a cancer tumor will distort the visualization of the collection system and prevent normal filling and draining of the renal system. Other tests include ureteroscopy or ultrasound with an IVP. You may need to order an MRI or CT so that staging can be done if it's a metastatic lesion. These patients are going to be referred to a urologist or a surgical oncologist. Treatment for a renal neoplasm is primarily surgical with a partial or total nephrectomy if no metastasis is noted. So your plan of care will be, your involvement will also be determined based on where they are in their treatment plan. And lastly, let's talk about bladder tumors. This is abnormal tissue masses that occur in the bladder wall lining. These are tumors that can commonly reoccur despite aggressive treatment. The patient may be asymptomatic until he has or she has hematuria that varies in severity from microscopic to gross. Other symptoms may be pain with urination, increased frequency, low-grade fever, weight loss, and urgency. On physical exam, you may be able to palpate a mass. Urinalysis will be needed to and may show trace or gross hematuria, and a CBC may show signs of anemia. Treatment depends on the type, the size, and the degree of the invasion of the bladder tumor, and these will be patients that are managed by urology or uro-oncology. These patients typically have urinalysis and cystoscopies every 3 to 6 months because of the significant recurrence of bladder tumors. All right, I believe that is the end of section 8. I appreciate your time. If you have any questions, please let me know. Thank you.